Well, thank you so much, PMD Alliance, for hosting this. It's great to see everyone out there. We're still a bit physically distanced here, but I think people are getting connected slowly. Hopefully everyone's doing well. So so excited to have Greg Pontone back, Dr. Greg Pontone from out on the East Coast, Johns Hopkins School of Medicine, and he's the director of the Parkinson's Disease Neuropsychiatry Clinic. He is a psychiatrist, and I am a neurologist, and I work here in sunny Southern California in Los Angeles. Yeah, I mean, I think we embody sort of the sense of the multidisciplinary team, the true sort of approach that I think is sort of the right one to take for Parkinson's patients. And hopefully we'll convince you through our talk about, the importance of mental health, the importance of the psychiatry piece of things, and also, how you can get some help and maybe some out of the box sort of approaches to helping yourself in this arena. So without further ado, welcome, Greg. Thanks for joining again. We have had a few chats on this series, and maybe the folks at the PMD Alliance can link, our previous interview or two. Yeah, it's just been fun to collaborate with Greg. And yes, maybe tell us maybe a little bit about your background, Greg, and what you do there at Hopkins, and then we'll talk a little bit about our topic today.
Sure. So I'm Greg Pontone, and essentially I trained as a psychiatrist and then did a fellowship in both geriatric psychiatry and neuropsychiatry, which sort of involves people who have comorbid neurological disorders, but also a fellowship in movement disorders. And so most of my work has been in Parkinson's and related disorders. And we think that having these neurological disorders modifies the way the mental illnesses present, and also is important in terms of how we modify how we treat them. And so we want to make sure that we take care of the individual in the context within which they present. So oftentimes there are additional needs because of these neurological conditions. And so hopefully having a team that has both a neurologist and a psychiatrist, or at least someone who deals with mental health, can give you the best results in terms of your quality of life.
So I think we can start maybe, I know we put together some slides just to sort of make a framework, and then we're happy to try to answer some questions in the chat as well. But we wanted to discuss this paper that we wrote. Greg, do you want to show them the paper? So I've been hosting this virtual support group here for the last almost 2 years now, I think. And when the pandemic hit, I became quite worried about how to keep our patients with Parkinson's socially connected, because I have research in loneliness in Parkinson's, and some of the first data on this topic and the importance of social connection in Parkinson's patients and their caregivers, and was quite worried about our patients and how they were doing when the pandemic hit. A lot of people were sheltering in place, and I just became quite worried about how to keep people connected. So we started the support group, and the PMD Alliance was literally overnight. I picked up the phone and they arranged it, and they've helped many of you figure out the Zoom, options and all of that stuff that I have no idea about. And so we've been having over 100 plus, interviews of different thought leaders in the field. And if you haven't checked out our past programs, they're all linked on YouTube and beautifully organized by the gang here. And so we wanted to sort of then focus sort of as we've been moving through the pandemic on some hotter topics, since we've been getting into some things on disparities, and then really focusing on mental health, because I've just been so fascinated by this topic and how important it is in my own life and my mental health, and how I've been sort of trying to deal with the pandemic and all the stressors. And I think that, as we've been following our patients, this has just become such an important topic for not just our Parkinson's patients, not just our caregivers, but everyone who's living on this planet right now. There's always something new and crazy to deal with. So we put together this paper really looking at the barriers to accessing help in the mental health arena. And we wanted to sort of tease that apart a little bit today. And Greg is, the senior author here on this paper. And we thought we would sort of walk you through a little bit of why this is important, and maybe come up with, brainstorm some things that you guys are doing in your own world to help each other come up with ideas of how to stay sort of more grounded in the mental health arena. So So in terms of why there are so many barriers, so mental health issues are very common in Parkinson's. And if you want to refer back to a number of the amazing talks that we've had, and actually the person who trained Dr. Pontone here, Laura Marsh, gave a beautiful talk on some things. We've had Dr. Dobkin, who's a psychologist, talk about depression. So we've just had a lot of different offerings. So we won't fully get into all of the nitty gritty, but there's a huge mental health burden in Parkinson's patients. And I think part of the problem with this disease is that it's been branded as a disease of motor symptoms, stiffness, slowness, and tremor. And so people only focus on the motor symptoms when they see patients, and patients think it's only a motor disease. And then we've also branded it as a disease of older white men. So people who are not that population tend to not be studied, not get care. And I just, we've been doing a lot of work in raising disease awareness around women who aren't getting care in Parkinson's, but, racially, there's a number of disparities and all kinds of things that we'll touch on. So the lack of disease awareness, which we can talk a little bit about. There's also a scarcity of mental health resources, stigma, which I'd like to get into with Greg a little bit today, some of the specific issues around COVID-19. We'll also talk a little bit about the archaic model of healthcare delivery. And I've been, giving these talks and trying to sort of understand now in the new normal of what we're all existing in, using telehealth modalities, connecting with a neurologist who may not be seeing you physically in person, trying to tell them about what's troubling you through, a screen, or coming in wearing a mask and having people really not be able to connect maybe as well from a facial expression or, voice inflection sort of way. And so how we can kind of think about the healthcare delivery mechanisms that we have in place and how we can kind of get a little bit of an outside of the box approach. And then we don't want to forget the caregiver as well in all of this. And we know that many of our caregivers have been tirelessly often the sole provider of care for our patients. Sometimes, people have had an inability to get help because help is not available. It's hard to hire people, but also because, having somebody come in could have been a risk for added infection risk and things like that. So many of our caregivers are going on into almost the third year of really a tireless sort of endeavor of often being alone in the home with their loved one taking care. And so we aren't forgetting you as well. And you as an engaged and healthy and well-supported person in this picture of health is hugely important for our patients with Parkinson's disease as well. And so when we think about the patient and the people who surround them in the model that we're talking about, it's really about also including the caregiver and loved ones and family and the community as part of this sort of description as well. So that's sort of the framework in which we, we'll be talking a little bit around this, the barriers. And then it's not all doom and gloom. Don't worry, we have some possible solutions, and we'd like to, find out from you also what you've been doing in the pandemic to kind of, like I said, stay a little grounded, and maybe you all can share ideas of what brings you joy and hope and has helped you get through this. So that's kind of where we are. So maybe next slide, Greg. So when we talk about the disparities, and, I talked to you about that, sort of branding of the picture of, who has Parkinson's, we've really done a disservice to many populations. And we've, I think, explored this here with the PMD Alliance as sort of our platform. And I think many of us have just been amazed at how we have not thought about many populations. And so race, there are many people of color, ethnic minorities that are not getting served. And we'll talk maybe about that a little bit, Greg, because I know that you work in a place that is largely, African-American populations, and you're not seeing these patients. So maybe we can talk a little bit about that. We spent a lot of time talking about gender and sex in the last few weeks. And, we will continue to try to explore that. But I just wrote a paper with some amazing colleagues about, gaps in care for women. So I urge you to take a look at those. There's been some recent exploration, and we had a guest on this program talking about LGBTQ, sort of issues, and this is an unmet need. Age, so younger patients with Parkinson's are often not served well because they have unique needs, especially in the mental health arena. geography. So if people are, rural or not able to access sometimes bandwidth from internet and things like that, that's an issue. And in our paper, we really found that geography and being physically unable to come in to some of these metropolitan sort of urban centers where the care is being given in these multidisciplinary teams was really a big barrier for our patients to get help. And so thinking about how we can get care into the community is important. And I think, with the digital divide that we're all experiencing, and the PMD Alliance has been brilliant in terms of trying to help many of our patients orient to using this technology. But if you can't afford a computer, you can't afford internet, you can't have access to these, or you may not be technologically savvy enough, or have other disabilities that prevent you from being able to interface this way, it's really a divide and a gap that is actually brought people even farther apart and not closer together in some instances. So that's sort of the framework. So maybe Greg, I will hand it to you to talk a little bit more about some of these things.
Okay, so absolutely. So we talked about this idea that mental health is complicated, and delivering it to people with Parkinson's disease, there's a number of barriers that have to be overcome. But now I want to just spend a little bit of time discussing why it is so important to, first of all, recognize that there's a mental health issue, and then two, what will be impacted if it's not successfully addressed. And so I want to show you this figure, and I think I've shown it here once before, but I think this is really important, is that if you look at the horizontal line, the x-axis, time zero is the time at which people with Parkinson's are diagnosed. So depression, for instance, can happen at any time over the lifespan, okay? In the red lines, that's times when it was diagnosed for the first time before people even knew they had Parkinson's. Time zero, they get diagnosed, and you can see that the blue lines are any diagnosis of depression after the time you're diagnosed with Parkinson's. And hopefully what you can appreciate here is that right around the time that you're diagnosed with Parkinson's is when there's the peak occurrence or peak incidence of depressive illness. Okay, so clearly the sort of burden of being diagnosed with a neurological disease, the symptoms of the neurological disease, and then eventually the medications used to treat the Parkinson's in this case, right, is something that basically happens to most people with Parkinson's. And so this is a very stressful time. So what we think is really important is that you should recognize that depression as early as you can and start treating it. Because if not, we think people have a lower quality of life. And believe it or not, and I'm going to show you some data on this, we actually think they function physically less well being depressed versus not holding the severity of the Parkinson's constant. And so let me show you what I mean by that. So the Parkinson's Foundation has the biggest study right now of its kind called the Parkinson's Outcome Project. And it's a year over year, or what we call longitudinal study of which treatments in Parkinson's produce the best health outcomes, okay? And that's whether or not it's the levodopa and dopamine compounds that help with people's movement or something else. And what they found is comparing everything that could happen to affect the sort of health outcomes in Parkinson's, depression had almost twice the impact of that of the movement symptoms of Parkinson's. And so this is a big message. This means that depression might be one of the most important treatment targets in all of Parkinson's. Okay, and so when we're talking about mental health, it may actually be that in some cases, it's more important to treat the mental health symptoms than it is even the motor symptoms. I'm not saying that you leave one out, right, by itself. You need to treat both. But if you neglect the treatment of mental health conditions, people will do less well over the course of the disease. And so here's a paper that we published on this topic. And essentially, we had a longitudinal study of Parkinson's that I think now is in its 20th year. We took a peek at about 16 years in. And let me just show you probably the one of the most important take-home messages of this study of depression and Parkinson's disease in a longitudinal study. So this figure is the horizontal line represents the number of years in the study, okay? And each point, each visit represents 2 years of a patient's life, okay? Now that the vertical line, the horizontal axis where it says NWDS, that stands for the Northwestern Disability Scale, okay? Now the Northwestern Disability Scale measures things like our ability to walk, speak, eat and feed ourselves, get dressed. So very fundamental activities of daily living, okay? Higher scores mean that you're more functionally independent. So for instance, a 50 would be more functional than someone who has a 25 would be more disabled on these physical symptoms, okay? Now here's where it gets really interesting. Each of these colored lines, the green solid line, the blue dash line, and the red dash line, means something different about their depressive status, okay? So people who are green were never depressed. So you can see that Parkinson's disease over time is a disabling disease. So just a little bit, people decline year over year, okay, with Parkinson's. We all know that's true in terms of their ability to walk, eat, get dressed, all of those things. But what I really think is important is that dashed red line are people who are depressed. And if you're depressed, you function less well at any point along that 6-year trajectory that I'm showing you here. Now, the good news is if we treat the depression, or if the depression spontaneously gets better, you go back up to a higher level of functioning. So the blue line is people who were depressed and got treatment and improved. And they're not only is their depression better, but their physical level of functioning has improved. Okay. And so this is why we think it's very important to both recognize and treat mental illness and Parkinson's, because it really sets the tone for your overall disease outcome. Okay. And so with that, we'll switch back to a more positive message. So that's what we're up against. And now we're going to tell you how to not only combat those negative symptoms of the disease, but how to go beyond and thrive and actually, live your best life with or without Parkinson's. And that's what a term we call wellness. And I'll let Indu take back over here.
Yeah, so we're excited to, the paper that we wrote was a lot of barriers. And maybe before we go into the positive stuff, we can spend a minute or two just talking about a couple things, Greg. So I wanted to just tease out a little bit of the concept of stigma, because I think that, we don't talk enough about this in our patients. And one of the things that we found in some of the women that we were interviewing was that, sort of the sense of getting this diagnosis, and there was sort of sometimes a shame or a change in their body image or something that they felt less than. And then that led to sometimes them not seeking care or not asking for help, and sometimes getting isolated. I think even with some of the, sort of the loneliness work that we've done, when you ask somebody if they're lonely, and, if they have social connection, or if they have to come forward and tell you that they're lonely, it's really something that's very hard for them. And, I think that it feels like they're not likable, or there's something really, wrong with them as a person, that they've done something to themselves, either both to get the disease itself, or to then, have done something to isolate themselves, and then, that they feel like they've lost their connections. And it can be a very vicious cycle, I've found. And some people, they have a hard time. Sometimes they get that diagnosis. There's a stressor there. Accepting the diagnosis sometimes takes some time and processing, and maybe there's a sort of an adjustment period. Sometimes the mood that comes along with the Parkinson's has been already problematic, maybe with anxiety or depression, even before the motor symptoms sometimes set in, which is definitely seen in many of our patients. Sometimes, like 10 years before people get motor symptoms of Parkinson's. Sometimes it can affect these non-motor issues like sleep, like mood, things like that. And then they sort of then take some time away from the world, maybe, and isolate, become a little withdrawn, and then it sort of self-propagates into this sort of then feeling uncomfortable sometimes with social situations, an apathy, sometimes a lack of motivation can also happen in many of our patients. And then, they sort of they find them, it's hard to engage, or they're not motivated to engage. And then they really sort of withdraw. So, can you tell me a little bit about the stigma and sort of what your sense of that is? And you see a lot of these patients sometimes later in sort of that cascade, right? Like when maybe something's not gone well and people are then needing to present, with our current healthcare model, to get a referral to somebody like you, Greg, it takes some time, sometimes a crisis situation to present itself. But, maybe we can unpack that stigma idea and the concept of, shame maybe as well.
Absolutely. So I think there's two levels of stigma, unfortunately, in Parkinson's. There's the stigma that people feel when they're diagnosed. They're less than whole, right? They've got something wrong with them. Already they feel like they've been carved out of mainstream society because they have this neurological disorder. And then, as you mentioned, when they have more advanced disease, oftentimes the symptoms are more conspicuous. And now they're worried, they're self-conscious, right? Because they're worried, are people looking at me? Am I scaring children? If I have dyskinesia, I mean, all sorts of things. And so, just as you mentioned, unfortunately, this sort of perpetuates that social disconnectedness and loneliness because they tend to withdraw. They say, well, I didn't really enjoy it that much before. And now with Parkinson's, I'm self-conscious on top of it. So I'll just avoid, I won't go to church. I won't go to the social activity. I'll stay home for dinner. And then, now you've got a snowball effect where they are now socially isolated in addition to having, symptoms and a poor mood. So that's the first level of stigma. And it's does for many people tend to progress, right? They're less likely to engage because of these concerns. The other type of stigma that we often see is some people are fine. They say, Parkinson's is a disease, they can see the Lewy bodies, it's, well accepted in society. But then mental illness like depression carries its own stigma. People sometimes with depression, people don't necessarily feel sad or even recognize that it's a disorder. And so they blame themselves, or worse, sometimes their family blames them. You're lazy, you need to try harder. Hey, just do more, as if it's some sort of character weakness. And it really, just like Parkinson's is a deficit of dopamine, depression is a deficit of the chemicals that help us regulate mood. And it's not your fault, and it's not for lack of trying, and it's not a weakness of your character. The problem is when it's unrecognized, you're used to, just trying harder. And no matter how hard you try, until you get the appropriate treatment, things just aren't going to go well. And so that's one of the big issues, is kind of recognizing it. And then once you recognize it, not blaming yourself, you haven't fallen down, and getting the right treatment so you can get back on track. And I think those are the things that people need a little help with, both in terms of their providers, the healthcare team that they're working with, but also their families and communities, to sort of be accepting that just like someone can have a physical malady, their mental health can need treatment and cause disabling symptoms.
And can you bring in the concept also of the people that are getting, in that disparity kind of group? Because I think that some of our research has shown also that if you're also in these sort of already under under addressed populations, that actually puts you at a higher risk also of some of these issues with mental health. And sometimes, I think with some of the subtleties of diagnosis, you and I have talked about the fact that, some women who are younger, for example, come in, they may complain of symptoms that are more in the non-motor realm, or something that's, maybe early anxiety, depression that might be related to Parkinson's, and, some unclear maybe motor symptoms that they're trying to express, and then they get diagnosed, misdiagnosed or delayed in their diagnosis, and then that puts them then at increased risk also, or even African Americans in different types of populations, for having more issues with mental health. Maybe you can teach us a little bit about those populations.
Yeah, I'm going to say a few provocative things here, and they're true historically. And I think we're still working on rectifying some of these disparities. And so I'm going to start with the thing you mentioned about a young woman presenting and maybe not being taken as seriously or having her anxieties misattributed. So, hysterical, right? How many people have been thrown under the bus because they're hysterical, right? You just need to settle down. Well, that's actually from the kind of Greek root for wandering uterus. So, that's very pejorative toward women. I mean, that's where the whole term comes from, is hysteria. The theories for that type of term were from this idea that the uterus was wandering around the body, causing all sorts of symptoms. And so now, like you said, you get a young woman who isn't the tremulous old man shaking. They're not thinking Parkinson's or necessarily going to land in the realm of the diagnosis that she may have. And so a lot of the things she's complaining of might be misattributed. Okay. And I think that happens, unfortunately. I can tell you of a case years ago where we have a regional system that gets all our neurologists together to sort of troubleshoot cases that might not necessarily fit neatly in normal boxes. And we had a pregnant woman who was likely presenting with first onset early Parkinson's. And, everything but Parkinson's was considered. She had the bradykinesia, the tremor, right? All the cardinal symptoms. But no, she's just anxious, and this has something else to do. And that was something where she paid consequences in terms of not being diagnosed and recognized as early as she could. And part of it was probably a gender and sex disparity issue, right? Had she been a man of a certain age, this probably wouldn't. And look, I'm not necessarily blaming this. It's still a clinical diagnosis. When we have biomarkers that are a little more reliable, we won't have to rely on this. But until then, I think we have to be acutely aware of disparities that confound assessment of this condition. So that's one. And then, race, especially with mental illness, I think race and ethnicity play a role, because cultures value the expression of emotion differently. And there's ethnicities and cultures where high expressed emotion is absolutely validated. And then there's others where, unless you're stoic, you're embarrassing all of us. And so I think this is something you really have to understand: the culture, ethnicity, and sex of your patient for various reasons. And if you're not putting that in your formula, I think you're going to have less than optimal treatment outcomes.
Absolutely. Well, I think also that we, as the system of education and how we're all subspecialized, and I treat neurological disease, which is a real brain disease, and then you treat psychiatric disease, which is more in the sort of fluffy whatever realm, which that's sort of also been this sort of misunderstanding of really what our specialties are about. And there's so many, I think, if nothing else, Parkinson's is an amazing model of how you can have disease that affects, proteins in the brain and certain sorts of things that we see on our slides, but can really have effects on things that are motor and physical. But then a huge amount of it is this non-motor burden and the mental health burden, which is absolutely part and parcel of this disease, which is why, people like you and Laura and Joel and so many of you are specialized in this area and are really trying to, teach us all about that and what you see every day and the patients that you're trying to care for. And, so I think helping people to understand that we work together, that I respect you and your work. And I think, when this paper came out, I sent it to some of the folks that I had interviewed over the last, couple of years as, sort of a tribute to like why I, brought this group together to write this paper, was really to bring out sort of and sing the praises of the importance of us all working together to help, with this disease. So I think it's really so important to sort of think positively about what we can do to affect change and bring our minds together to really think about how we can help patients, in a positive way. So thank you for joining me in this journey. And I think, for the patients that are and caregivers that are out there listening, if there are some of these issues in the mental health realm, hopefully, if nothing else, from this chat today, you can take away that these are real. This is part of your disease, and that there are ways to get you help, and that, advocating for yourself and getting educated around this, and taking this seriously. And if somebody offers you, help in these arenas, I would definitely take it, because, it shouldn't be that, oh, I'm happy to take these medications because they're for my physical symptoms, and everything else isn't real, or, is sort of discounted. And then that's really where our patients suffer, is when they're not accepting and understanding what they're sort of dealing with themselves. And then, as Greg just showed you, it can really affect quality of life so, sort of dramatically. And when we treat patients, and there are people that I see for the first time that walk in with terrible anxiety or terrible depression, I don't even consider starting a motor medication in that regard. I, will first treat the underlying mental health issue, or get them help in that. And then, once we've sort of treated that, it then bodes much better, right, for how they're going to do from a motor standpoint, from cognitive standpoints, from many, many standpoints, right? Could you just speak to that, sometimes treating the underlying mood issues and how they may impact then the physical issue and the overall well-being?
Yeah, absolutely. I think sometimes we have early unmasking of Parkinson's when people are in a depressive state or an anxious state, for instance, and that by treating those, not only do we get sort of improvement in the anxiety or depression, we get some mitigation of the movement symptoms, or at least the distress that the movement symptoms are causing them. And so I definitely think that these have to be treated in parallel, and missing one of them is going to give people a less optimal outcome in terms of their quality of life. And there's even studies that show that people who had been on antidepressants prior to diagnosis have a longer time until they need symptomatic therapy for their Parkinson's. And so that's sort of, I think, what Indu was referring to, is that there are people who are treated for their mood who might 6 months or a year advantage on other people who aren't, and start treatment sooner for Parkinson's. And so how exactly that plays together, we're not sure, but it's been replicated half a dozen times now across different study cohorts.
Yeah, that's so interesting. Okay, well, cool. So it wasn't all doom and gloom. We thought about the barriers. We showed you those bubbles, and we thought about, how to address these barriers. And so it's been kind of an exciting time frame, I think, with 2020 and beyond. In some ways, this sort of pandemic really, I think, highlighted a lot of issues in many of the things that we haven't been doing well, and really made many of us as providers think outside the box in terms of how we could get better care, and really sort of the sense of a patient feeling like they're part and parcel of driving their own bus in terms of how they do. So we propose this pyramid. We'll sort of unpack it a little bit for you. So the first step in this pyramid to getting better is really education. So understanding about the disease. We've talked to you a little bit about how important, how common mental health issues are in Parkinson's. So 40% of our patients get depression, anxiety, 40% apathy, these, cognitive issues. All these things are part and parcel. Sleep issues, huge percentages of our patients get these. So understanding that these are part of the disease, understanding what they look like, and if you want some advice, you can go back and watch some of the YouTubes that we've had, number of presenters talking about this. Destigmatizing this, so understanding that this is, it's not your fault, that this is part of your disease, but you didn't do anything to cause it, and we can help you, and that you shouldn't feel ashamed to ask for help, and helping your family understand that that's part of this as well. And then really accepting that multidisciplinary approach. So understanding that I, as your neurologist, am not the only person in the world who can help you in that 15 minutes or 30 minutes that I get to see you once in 6 months, that there are a host of providers, including people who are psychiatrists and psychologists and social workers. And it's a team, it's a physical therapist, all kinds of people. And that team may include even your religious leader, your priest, or your rabbi for some of my patients. It might be a yoga teacher, whoever can be your cheerleader and kind of hold your hand and sort of help you is part of that team as well. So that's the first step. Empowerment, we'll talk to you a little bit in the next slides about that. Realigning the healthcare team in the community. So we talked about how maybe coming into my, ivory tower once in 6 months does not make sense for a lot of people who can't drive in. So thinking about what you have in your community, and even if you don't have a movement disorder neurologist, you might have the a great physical therapist who loves taking care of Parkinson's patients and loves, bringing patients together, or a great support group leader who's in your team, in your community, who can help guide, some people to get together and do certain activities in a group. So really think about what you have in your community and try to engage that, thinking about who we're not reaching. And if you happen to be someone who is more privileged and more able to get some of these resources, and of people who may not be able to or not getting care, help lift them up and bring them along to get better help. Because actually volunteerism and helping people actually is great for your mental health and for your well-being, and gives you purpose. And so the advocacy work that many of you are doing is actually very important. We'll talk for a minute about social prescribing as well in a second, and then also the concept of self-agency. So we'll unpack a little bit of this. So next slide. So Greg put together some of these slides, but I can talk about this since this has been really my passion. So what is wellness? He mentioned this. So this is really the state of optimal well-being, not merely the absence of disease and infirmity. And it's really sort of that's what defines health by the World Health Organization. So it's really this complete state of mental, physical, and spiritual well-being is what the World Health Organization in the 1940s defined health as. And so I think, unfortunately, we have sort of led ourselves away from that definition and just really adopted a sense of a symptom and trying to treat a physical symptom. And then wellness is really this active pursuit of activities, choices, and lifestyles that leads to a state of health. And so that is something, as a patient living with Parkinson's, that you have choices that you can make every day, and hopefully lead to sort of a sense that you can grow into thriving, and not just merely sort of a sense that you are curing a symptom. And maybe I'll let Greg show this slide and explain from his terms what this is about.
Yeah, no, absolutely. So this is really just a recapitulation of what Indu just said. And basically, if you look, the traditional treatment paradigm is that short white arrow on the bottom. And it's basically saying, hey, you've got the symptoms or signs of an illness, okay, whatever it happens to be, whether it's an infection or Parkinson's disease, and it's causing you disability, and ultimately, left untreated, it will lead to premature death. And so most of Western medicine only addresses that left side of the slide, okay, that part of the arrow, okay. What it leaves out is really having the optimal quality of life, enjoying things, being more aware, educating yourself, growing with or without an illness, right? Isn't that what we're all supposed to be doing? And so the wellness paradigm not only spans that distance from preventing premature death and treating the sort of adversive symptoms of an illness, but thriving, going beyond that to enjoy yourself, to be part of your community, to raise your children, and to be part of your family and contribute in every way you can. Okay. And there's many chronic diseases, Parkinson's, diabetes, cardiovascular diseases. We all still need to go beyond the center point of this arrow. And so wellness is really making choices that allows you to live that lifestyle. Okay. And it's an active thing. Okay. And if you're presented with a challenge from the disease, it's about overcoming that challenge and continuing to pursue the blue part of this diagram: growth and education and awareness.
So I work at the VA. I run one of our 6 centers of excellence in the country, and I have a background in integrative medicine, which is sort of the medicine between Western medical approaches and other sort of approaches like traditional Chinese medicine and Ayurveda and yoga and mindfulness and all kinds of other backgrounds. So really this concept at the VA has been adopted where the patient's in the middle. There's a number of lifestyle choices that they have, including the things that surround them and the community that they live in, the people that they love, the relationships that they have with them, and a lot of other choices too. So things like, sleeping, what you eat, your exercise, getting moving, all these sorts of things. So these are really sort of a sense that all of these things that we do every day can kind of work together to make us feel better. And these are personal choices. And when we feel, at that tip of that pyramid is that sort of sense of self-agency that we, are in control of our outcomes. Actually, there's a lot of benefit to that, right, Greg? Tell me a little bit about this sort of sense of self-agency and what that can do for a person.
Absolutely. So, if you're in a reactive state and you feel as if things are happening to you and things are falling on you, you're not empowered to make changes. So you have to feel that you're the sort of custodian of your own life and that you're going to, direct your life in the direction that you want it to go and not let the disease sort of blow you in one direction or the other based on its own, the sort of luck of the draw. And so this is very powerful concept because oftentimes people can feel defeated and then they stop trying, and that's the way to lose. Is you have to keep putting forth an effort to overcome, and that's true of all of us, but I think it's especially true when you're dealing with a disease like Parkinson's, right? You have to basically meet the challenge each day and sort of grow a little bit and educate yourself about how to do a little bit better.
And so we'll go to the next slide. So it's important to also realize that that wellness concept is not the same for everybody. So it's very culturally contextual. So, something that may be what a person loves, like, dancing with their wife, maybe to salsa music while making tamales in their kitchen, may be different for one person. For somebody else, it might be playing with their grandchildren on the floor that really brings them joy and meaning. For somebody else, it might be playing golf. It might be, doing a hike, up a hill that they love every day, and they look forward to that every day. So what sort of when you wake up in the morning, kind of what do you look forward to, and what really brings you joy and meaning is something that we want to help our patients identify. And this is very culturally contextual. So a lot of what we've done historically is study white affluent men who are married, and figure out what works for them. And then we try to extrapolate that and tell people who are Muslim, who are, in women in England, to go to a gym and exercise on a treadmill. That's not going to happen. I'm not going to do that. So we really have to think about the cultural context. And I love this slide. This is by the First Nations, and for them, the land, their ancestors, the other tribes, that is something that's very much part of what brings them meaning and is important to them. Next slide. So there are novel ways to think about, the outside of the box, not having to just go to a neurologist and then get a prescription to see a psychiatrist, and these sort of feelings that you're, don't get to have support in the mental health arena if you can't, go in and get this. And I think we've already seen in the chat that people are having hard time accessing some of these referrals, and, people are booked out and stuff. So what can you do? It's important to think about the people that you have already in your community, or possibly part of your support group. And our patients themselves have come up with some of these ideas. So Ben Stetcher told me about the idea of having a mental health check-in buddy. So he has a friend who also has Parkinson's, and he checks in with them once a week and says, how are you doing? How was your week? Are you doing okay? And that was his idea. So I think that's a brilliant idea. Sharon Krisher, who's one of my patients, runs Twitchy Women. They've come up with this mentoring program within their support group, where women who may have had Parkinson's for a little longer, mentors literally is paired up in a mentorship program with another woman who may be newly diagnosed, and kind of walks alongside to give her support. And that was something that they created as patients. So I think thinking about, ways that we can, utilize the people in our own communities, because we have to face that our healthcare system is not at all perfect. In fact, it's quite broken, and we have to figure out of the box approaches. Health coaches, we have some of these at the VA. Community health link workers have been proposed as part of this concept of social prescribing, where you may have a doctor think about a patient who might be lonely and try to use a link worker, maybe a social worker, maybe it's a support group leader, and they find maybe a group that can fit with what you enjoy doing. So it might be, a gardening group, or a yoga class, or a, group of veterans, for example, that meet with Parkinson's. So, again, thinking about outside approaches. And this sort of concept also that we have, mental health workers that are very, very overstretched, who are classically trained, but maybe there's some allied health workers that can be trained. And I think this is starting to happen in some parts of the world. I'm not sure how, I think it's state dependent as to who can give this care, but, some outside of the box approaches. Next slide. or at the question side. And I think, just Greg was kind enough to allow us to use him as a great speaker today, but he has to run to an engagement that he has to go to. So I will be hanging out answering some questions, but if there's a question maybe for Greg that we can take, there's one question, Greg, that I just wanted to ask you real quick. There's been this question about this medication that I'm actually not too familiar with. I don't know if you saw it in the chat here, Trintellix. Could you just answer that question about what do you think about this in Parkinson's patients? And then I can take the rest of the question.
Yeah, there haven't been formal studies of that particular medication, Trintellix, in Parkinson's, but it is an antidepressant that's been demonstrated in non-Parkinson's populations. And so we're actually keenly interested in that particular compound because it might also help cognition while it's helping depression.
Interesting. What is it exactly? I don't know enough about it. Maybe just tell us a bit.
It's sort of in what we call the SARI class. So it's a serotonin agonist and reuptake inhibitor. And so it may have unique mechanism that promotes helping these other symptoms.
Fascinating. Okay. Well, I think we will let you head out, Greg. Thank you so much for spending the time with us. It's always such a pleasure. And I mean, I think it's fun to find a psychiatrist who drinks the same wellness Kool-Aid as I do. So it's just been a pleasure to write with you and to get some of this stuff out there. And I think, we're still a long way from realizing some of these goals and ideas, but, hopefully we can work together to move the needle into a positive space. So, so the drug was Trintellix, I guess. That's novel and new, but we still don't have data, as Greg had said. I'll let you go, Greg, and I'll
thanks for having me.
Yeah, thank you. Be well.
Bye.
So I think, we have about 10 minutes left. I'd love to find out, given what we just talked about. So, we talked about a few things. So one was the concept of education empowerment. We talked about lifestyle choices that people can choose every day to try to help themselves, with making choices that, exercise is medicine. We have a lot of data mounting now with in Parkinson's patients that exercising, getting good cardio, maybe for 30 minutes, 5 days a week, is actually beneficial for, the outcomes of this disease over time. There's been a concept of eating, a Mediterranean diet. Part of that wellness prescription is actually social prescription from my perspective. So finding ways to engage with other people and connecting socially on some regular basis, as part of that prescription, getting a good night's sleep. So if you can sleep 8 hours, that's important to feel restored. And as part of that wellness prescription, the mind-body practices. So I've been really interested in yoga and mindfulness as important things that may help our patients, but thinking outside of just those classic ones. Tai Chi is also in that, but even maybe taking a walk in nature, getting out in your garden and spending some time in nature, prayer, getting into a flow state by doing some artwork or playing music or listening to music, and really kind of getting, in sort of a mental state where you're sort of enraptured with that experience is something that I think is counts as well. So I'd love to see in the chat what people are doing and what has resonated with people, and maybe we can help inspire each other. So if you want to put what you've been doing, and also, so there's been some ideas, some questions, and maybe Andrea, you can also help me to help people, because a lot of these questions are around actually getting help, in some of these remote places, and how to get connected with good resources. Let's say you don't live anywhere near a big city. What would be sort of, if somebody called the PMD Alliance and was asking about this question, what would be your sense of like what the right answer would be there?
Well, we have a website full of resources to help people find a clinician, find a support group, find a Parkinson specific exercise group, and all across that pyramid that that you had as a visual, ways to address many different steps on that pyramid. And I think all of them do lead into that concept of self-agency, being able to make choices about, what you eat or which exercise class you go to or starting a support group. And I think there was a question in the chat about just self-agency maybe is uh, a hard concept or term to understand. And someone said, does that mean control of your life and being hopeful? Would that be an appropriate way to explain self-agency?
Yeah, I mean, I think self-agency is basically the concept that you can kind of be your own sort of master of your destiny to some degree. And it may not be wholly, but in some ways. And I think what we found in many ways from a psychology perspective is that when people feel like they have no control of the situation and they're just literally like floating in the wind and everybody else or everything else is in control of their destiny and not them, then that's like the worst outcome ever. And that actually leads to a really bad sort of sense of quality of life and a really bad sense of, sort of outcomes from many, many measures. When people feel like they have control over something, and some of this work actually comes from the work of Viktor Frankl, who I'm a huge fan of, and I ended up recording a TEDx talk on this concept as well. It was sort of the sense that even in those concentration camps in that horrific time frame, when people felt like they all this badness was going on in their lives, if they felt like they had some sort of sense of control of something, and it could be just what they did that day or helping somebody else or whatever they could affect change in their sort of sphere, that actually led to a better outcome. And it may be even your reaction to something. So something bad has happened, somebody dropped a bowling ball on your foot and you're like, I'm going to punch you in the face. But if you can take a moment and just be sort of non-reactive for just a second, and you can just say, like, I have a choice here to react in this way or that way. It was a mistake, like the guy dropped a bowling ball on my foot and I could punch him in the face. But just that choice, and realizing that you may have as a human on this earth some choices, and it may feel like it's overwhelming, but it might be a choice to sit down and do 5 minutes of a breathing exercise. And even for our caregivers, it might be taking 10 minutes for yourself today and doing something that you love, or buying yourself a luscious something that you just love and treating yourself to that, or spending some time in a hot bath for 5 minutes. That choice is actually quite powerful. And so I think that we don't realize that psychology of how much it affects people. And what people do is they spend a lot of time thinking about the past and a lot of time thinking about the future and worrying about those things. And that's actually not very helpful to anybody involved. And I spend a lot of time teasing out what really drives a lot of the stressors in my patients' lives. And it's about their like son-in-law and something he did, and you have no control over that. Why are you worrying about that? Worry about whether you're going to take a walk today. Worry about when you set your bedtime so that you can go to sleep and put your phone away and don't look at a bunch of devices. Worry about, the things that you have control over. And it's fascinating because everybody else is then worried about the patient. They're worried about somebody else, and nobody actually is worried about the things that they actually have control over. And then, it ends up being just a bunch of people who are not thriving. So I think thinking about, you as a person on this planet, what do you have the choice to do today? And it might be just a small thing. I'm not telling you to take 10 things and do all of them all at once, but realizing that these small pieces can actually, maybe call a friend and spend 5 minutes talking to a friend that you love, and you're helping them too, because they're also lonely. So these are the types of things that we're talking about. It's like these bite-sized little pieces of things that add up. But then, when you add them all up to positive changes and you're not just dwelling in negativity or things and feeling out of control, it can actually be very beneficial. So, yeah. And you heard that from a neurologist and a psychiatrist today, who have probably between us about 30 years of experience or more treating patients with Parkinson's. And I think this is some of the secret sauce that really can, make a difference. So, yeah. We don't have a lot of time left, but like, is there another quick question?
Well, I think that's a lovely way to close when you
Okay.
think about all of the choices that we do have control over, and that wheel of whole health, our surroundings. Is it lighting a candle and enjoying that? Is it having a cup of tea? Is it going for a walk? Is it tuning into this program? I think that's a beautiful redirect on, instead of what's going on in the world beyond our control, what's going on in our body because of disease progression or because of a family members. That is a reality, but we have that whole other wheel of things that we can control. So.
Absolutely. Yeah. And it's so important. And these small choices can make a difference. And you're not alone. I mean, I think when people feel overwhelmed and they feel like it's just them, like many of us are feeling overwhelmed and many of us are feeling all the same things. And it's not until you get together. And I think that's been the beauty of some of these support groups when, women get together and talk about this and that, or caregivers get together and talk about this and that, the shared human experience of that connection and being able to listen to someone else who's having the same thing as you and seeing their face and holding their hand, or even on the phone, listen, that's actually very therapeutic and something that we've unfortunately as doctors and as people have really unfortunately gone so far away from. It's quite stunning, so I know I miss a lot of my friends and a lot of my family, and I feel so much better when I can sit down and have a glass of wine with somebody and share a common experience or laugh about something. And so these basic things are actually like medicine. Exercise is like medicine. It's not always about pills. It's not always about deep brain surgery. It's always, something you go into the doctor and we're always trying to fix something, a symptom, and then fix it. But think about the things that every day, literally from day one of diagnosis of Parkinson's, that you can do or that you wish you had done, and try to sort of drizzle that in and help other people to understand what works for you. And I think, these support groups are invaluable with that kind of stuff. And so I'm so grateful that we've had, this space to kind of talk about some of these out of the box approaches. And I know for me, it's been a lifeline, many of these wellness approaches. And so hopefully we've been able to share some of that with you today. And I'd love to, sort of continue to see this sort of stuff percolating. And I think, the longer we do this sort of stuff, I think we realize that this is some of the secret sauce. So wish you all well out there. Thank you for having us. And hopefully we've, if nothing else, helped you to understand the importance of identifying mental health issues and talking about them and getting some help in this space. So be well.
Well, thank you. And we'll relay our thanks to Dr. Pontone as well. To hear that message from a neurologist and a psychiatrist with supporting data, that is so powerful. So thanks to the both of you for being thought leaders in this field and for sharing all of your work with us, sharing the paper. And as always, I invite everyone to close with a wave of gratitude. Thank you all for being here. Thank you, Dr. Subramanian, and thank you for this beautiful hour that we all spent together.
You're welcome.